I'd now like to introduce Cathy Gallagher. She's the Division Program Manager for the Detroit Division of the Drug Enforcement Administration. Cathy has routinely conducted inspections of DEA registrants, such as manufacturers and distributors of controlled substances. She's conducted complex criminal, civil, and administrative investigations of pharmacists, physicians, and well-organized prescription rings. Here today to discuss how the DEA is combating the supply of opioids, heroin, and other controlled substances. Let's welcome Cathy Gallagher. Thank you, Cathy.
I don't know if I'm the gorilla in the room or... First of all, I want to thank you. What a marvelous day. I've recently transferred to Michigan. It's my new adopted state. I'm from Washington, D.C., where, you know, it's the world of positive feelings in Washington, D.C. Not really. I've come to a part of the country where you all are so nice. You just don't realize how nice you are. And I say this now everywhere I go. It's probably becoming boring. But it truly is. My husband's a New Yorker, and he says, you know, everybody asks me, how am I doing? And I want to say, who wants to know? And, you know, that's how we are on the East Coast. We're really guarded. And I've worked at the national level for a long time, and you become kind of jaded, and you get overwhelmed with the epidemic, the crisis, all of these negative terms. And we're law enforcement, so we tend to deal with the negative side of things. And you sometimes, and I'm an extremely hopeful, positive person, but even still you kind of think, gosh, how can we do this? And I realized, and as the judge this morning said, she's not a crier, I tend to be a crier. I realized that law enforcement, we don't have to do it alone. We are a partner here. In this room, it's just so beautiful. And I'm leaving today so hopeful. And I thank you. I've 32 years I've been with DEA, and I keep thinking we're not getting it right. And I see now we're starting to get it right by the collaboration, by talking about recovery, by talking about the disease. But also what I want to do today is talk to you about what we do so you understand our role at the table, because sometimes the finger pointing is always there. We point in insurance. It's all a lot of finger pointing. But I think it's important for you to understand what our role is. The other common themes that I heard today, if you were going to ask me what are the important things, I would have said securing your meds. We've heard about that today. Also about disposing of your medications. I just got a text saying the May 20th, they've just asked DEA, would we receive all the medications? That's a whole other issue I've got to deal with. But, you know, disposing of medications, educating practitioners, educating pharmacies, educating the public, educating children on the dangers of it. We're a society that says, oh, I don't feel well, take a pill. We really are. I'm the same way. This morning I started my day with a Tylenol. You know, as you all were talking, I'm like, this is not right. I'm popping a Tylenol, but it was just a Tylenol, I promise. Treatment and access is important. We've heard that today. So one of the last parts is how do we combat the supply? And I'm hopeful that some of the things I'm going to tell you, some's going to be really boring. I know that, especially at the end of the day. But some of it, I'm hopeful you will just understand what one part of DEA's role is in the combating of the supply, because we've kind of have a tough job. So the first slide is going to be a little sad. Not that one, that's just me. That one. That's the reality of law enforcement coming up on. When I see this, the first time I saw this, I just cried. There's that child in the back who doesn't know, who's supposed to be safe, and then you have two people who have an illness. And that just sums it up. It doesn't get any worse than that. So we only can go up from that, right? And Cynthia this morning, I appreciated her slide. I'll move on. I want to just show you, just follow the pictures. Okay, so this is 1999. This is drug overdoses in the country, CDC stats. I have them up to 2013, and my statement was going to be, I'm scared to see 2015, 16, and we saw that already. But you can see your part of the country, which now is my part of the country. I know the MIT. I'm learning your cultures. I can't say Washtenaw. I can't say that yet. But I love your state. I get it. I get why this is the most wonderful part of the country. But I never really looked at Michigan before until now. I cover Ohio. I have 7 offices that report to me, cover Ohio, Kentucky, and Michigan. Michigan is the state I love the most today. If I'm in Ohio, I'll tell them that. You know. Okay, so watch the color change. Florida is now ground zero, and you've got West Virginia, Kentucky, and we're moving up. So now we're at 2008, and we've had a lot of statistics this morning. If I had more time, I could go into explaining things, but I think you got the picture. This is 2013. So we know 2015, we saw this morning, Michigan is in trouble. But what I'm hearing today is there's hope. I really do. I'm leaving, this morning I'm leaving here hopeful, and it's because of the work that you all are doing, and we appreciate being in the room. Okay, so this is your normal doctor's office, right? No, this is Florida. This is a reality that Florida, when they were ground zero, was dealing with a rogue pain clinic. I think you would say that's a red flag, and I think you would agree that DEA needs to look at this. What's going on there? Now, in that line, there's individuals who have issues. They either own themselves, are addicts, drug seeking, or maybe they've been in a bus from New Jersey and they've been driven all the way down to Florida to go into the pharmacy, to the pain clinic to get drugs to give to the person who brought them there to sell it. Those are the individuals that we're going after. Those are the people who are providing those medications, well-organized prescription rings, those guys. The individual person who's dealing with an addiction is not DEA's role. That's not our lane. We're not looking at that. I promise you that. They get caught up in it sometimes. Here's another one. Okay, so now the boring part. So we have, within DEA, we have the Office of Diversion Control. It's kind of an interesting program, and we have a two-sided mission, twofold mission. One is obvious, to investigate the diversion of legal substances. So substances that are being diverted from manufacturers, distributors, practitioners, pharmacies, we investigate. That's clear. The other side is to ensure that there's an adequate supply in this country. So we establish quotas. What's the legitimate medical need in the country? Are all prescriptions legitimate? Probably not. We know 99% of the doctors out there are good doctors. There's that small percent that choose to go a different way, and we'll talk about that briefly. So we have to balance. If we allow more controlled substances to be prescribed, is it going to automatically increase diversion? And it's kind of a big burden, and we get scrutinized constantly on the quotas. Then if there's a shortage, then DEA is blamed because there's a shortage. So that I'm used to it, I'm thick-skinned, but it's not an easy job. And DEA is the competent authority under the United Nations. We signed 2 treaties that we say, as a nation, we're going to watch the drugs that are imported, that we manufacture, that we consume, and we have to report to the United Nations. And I'll tell you, the United States is constantly being criticized by the volume of medications, controlled substances that we produce and consume. Now, I think we probably have one of the best healthcare systems in the world, so maybe people are getting more access to treatment. But still, there's a lot of medication in comparison to other parts of the world, and the other parts of the world look at us critically because of that. We monitor imports and exports. We monitor rescheduling of substances like hydrocodone, went to a Schedule 3 to a 2. I'm going to talk about that quickly. Quotas. We're liaison to and policy development. We write regulations. We're the feds. And we're a registrar to about 1.6 million DEA registrants. I'll show you that in a second. And we track what moves through the chain of distribution. Now, the individual practitioners' prescriptions we don't see. We see aggregate data. For some reason, a lot of physicians think we're behind every bush and every tree. You're going to watch every prescription that's written. Federally, we don't do that. And we don't even have access to your system, your state system, which the revamping of it. I've been here 4 months, I should say, so I'm really a baby to this part of the country and your state laws. But I love your new program, the revamping. It's going to be such a good tool for healthcare providers. And if there's a question whether to prescribe or not to prescribe, it's going to give them the power of that tool. But we monitor aggregate data through the chain of distribution. So we fall under the Controlled Substance Act. That's our law. And it sets up this closed system of distribution. It says anybody who wants to legitimately handle controlled substance has to be registered with DEA. So we register importers, exporters, manufacturers, distributors, pharmacies, practitioners. DEA is even registered with DEA, which is kind of funny. Our fee is waived. We don't have to pay the fee. So, but once it goes to the patient, It's out of the closed loop of distribution, except now we have new law that allows us to take it back because of disposal. I could talk a whole day on disposal, but I don't have much time. But that's our closed loop. So DEA's responsibility is to make sure everybody who's registered with DEA complies with the federal law and regulations. So types of controlled substances, obviously narcotics, stimulants, depressants, hallucinogens, steroids. And I won't give you a history on what's a controlled substances, but I want you to look at what is federally, what is a Schedule I substance? Marijuana. There, it's a whole nother hour. We could talk about that. But Schedule IIs are drugs that have legitimate medical use, but high potential abuse. Schedule III substances, we go down in the level potential for abuse. I give you hydrocodone. I just realized my slide is wrong. If you caught it, then you get I have a Hershey Kiss. I'll give you one. I was just reviewing, and I'm like, oh, that's a slide I didn't update. So hydrocodone is now a Schedule II. I apologize for my mistake. And then Schedule IVs are generally your benzodiazepines, and Schedule Vs are kind of like your cough syrups. So Schedule IIs have more stringent, you can't get a refill of your prescription. There's more stringent rules because of the high potential for drug abuse. So how does DEA maintain this closed system of distribution? We have a couple things that we do, a few things that we do. We have diversion investigators. I'm a diversion investigator, like I said. I've been with DEA 32 years. I'm at kind of the end of my career, and that's why you all today gave me hope, because I get to the end and you think, gosh, did I matter? What I did it matter? And I realize, I tell people, I have new investigators, I'm like, if you save one life, it's not just one soul you saved that whole family around it. And you have to take it one soul at a time. You can't take it all on, otherwise you get paralyzed. But anyways, we establish schedules. So a drug is in a schedule. We have registration. You have to be registered with DEA. We establish quota for certain base products, the pie, and manufacturers have to come in and say, okay, this is the projected sales, this is what we sold last year. There's some scientific mumble jumble that goes into it. We assess the number of prescriptions filled, and just because the prescriptions were filled, that doesn't mean we should increase the quota, but the quotas becomes a political nightmare. Especially inside of a pharmaceutical epidemic in the country. DEA, why are you increasing the quota? And that's another whole discussion. ARCOS is how we track. We can see what's going through the chain of distribution, where manufacturers are moving to distributors. We can see what's what's out there. And then security requirements. Depending on your registration, you have certain security requirements, and we need to make sure that you're providing the adequate security. And record keeping. I'm called a pill counter. That's really, record keeping is the core of what we do. We go into certain companies like manufacturers and distributors, and we do drug audits. We do surprise visits. It maintains the integrity of the system. It's kind of like, speeding. If you know they're watching, you're going to slow it down, but you never know where they are, right? But I am learning you drive awfully fast here, and I'm learning where those speed traps are, but I slow down, right? So the same thing with our system of inspections. They don't know when we're coming, and so they're going to always do the right thing. And then and we do scheduled investigations. So we go out and do these investigations to make sure that they can account for the drugs and the drugs are secure. So this is just a quick snapshot of our type of registrants. Practitioners make the most of it, but let's do this one. So in Michigan, these are the people who are or entities that are registered. You have 16 manufacturers. These are all legitimate. You have 22 distributors. You have 37 practitioners registered. And I want you to jump down. You have 37,000 practitioners registered in Michigan. Look how many are data wave practitioners. Those are doctors who can provide drug treatment. There's something wrong there. You should have more doctors. And you heard why. There's lots of reasons why, but 37,000, if you imagine if each of those doctors, if their practice was appropriate, took 5 patients for some kind of drug treatment, opioid treatment, it's a lot of people that they could deal with, right? And would be more manageable, it seems to me. I'm not a specialist in that area. We have about 9,000 nurse practitioners and PAs. That's the largest growing registrant population. across the country, and there's about 2,500 pharmacies. You only have 44 opioid treatment programs. I shouldn't say only, because there's some states that only have like 2. I mean, and then there's some states that have thousands. An opioid treatment program, some places can treat up to 1,000 patients, which is a lot in my mind, but you know, we got to get the care, we got to get the care. In Ohio, they have treatment programs that are treating 2,000 people. It's a lot of people. So how do we here in our field office combat the supply? We do regulatory inspections. We monitor the chain of distribution. We look at suspicious orders. One of the things when we go into, we meet with distributors, and you've probably seen in the press some of the civil actions that we've taken. We're requiring manufacturers and distributors to know their customer. Who are you selling to? And I have to say, back in the internet time in 2008, when you saw all those spikes, DEA wasn't, our systems weren't up to par. We were not watching the massive amount of drugs that were going to Florida. We were kind of asleep at the wheel. Industry was so mechanized, they weren't looking at it. No one was looking at it. And then when you step back and you look at the data, where a registrant could have looked at all thousands and thousands of dosage units going to a small little pharmacy, let's say in Sanford, Florida, when there's other pharmacies around, you know, something, red flag should be there. We are holding the pharmaceutical industry accountable. Do your due diligence. Know your customer. And it's a painful process for some. Others are getting it, but that's our job to make sure that they are accountable. We monitor theft and loss. We look for trends, hot spots, what's going on. We do criminal, civil, and administrative cases. So in Detroit, we have 2 diversion groups. I have some of my diversion investigators are here. We also have who do the regulatory component. We do some criminal, but primarily we're regulatory. We also have 2 tactical diversion squads, which are made up of diversion investigators, special agents, and task force officers that are committed to this, to do criminal investigations, to look at those doctors and the pharmacists that are putting a lot of controlled substances on the street. Administratively, it's a powerful tool, but it's not a quick process. That's the most frustrating thing for investigators. We'll go out and do an inspection, and if there's violations, we'll do a letter of admonition saying, these are things, some problems, you've got about 30 days, let us know how you're going to fix it, because we want you to be compliant. If you're compliant, it's going to reduce diversion, and that is always our goal. I don't wake up and say I want to put someone in jail today. There might be some people that do that. I do not do that. How do I help you comply? How do I make sure that your record keeping is intact so that diversion's not occurring? Because if diversion occurs, there's deaths, right? There's sadness, all those things. So that's always our goal. Compliance is always the goal. Sometimes you have to do tough love. Sometimes that means criminal. Sometimes that means a civil fine. If you're not getting it, a letter didn't do it, but we have tools in our toolbox. Memorandums of agreement's a little more severe, saying, okay, we both agree that we've got some problems, we're gonna do better. If there's imminent harm to the public, we have the power to do immediate suspension orders, where we come in and we take your DEA registration, we take your controlled substance, and we put you out of business until the due process happens. But we have that. And then we have order to show cause, which is an administrative proceeding. You have to prove to us why you should not have this registration. It's not a fast process. If you talk to most investigators, we would agree it's not fast enough. And then we do criminal and civil cases. And if you go on our website, you will see some of the cases that we do, because I don't want any physician to be afraid of DEA. But if you go on our website and you read some of the cases, you'll go, oh, I'm not having sex with my patients. I'm good. I'm not giving oxycodone for heroin. No, I'm not doing that. I'm good. I think you'd see the type of individuals that we go into. And I think what's amazing in my career, when I investigate a doctor, and you can see at some point they probably were a phenomenal doctor, and greed or whatever, something switches, and they justify it, and it just spirals out of control. Greed is a big one. Now I've got the big home, I got the, and then people are dying, but they don't see it. But there's always a point in investigation you can see where they switched. I'm going to give you just 2 brief, I have 5 minutes. Ooh, so much more time I need. I want to show you real quickly, legally, federally, what's a legitimate prescription? Because I think it's important to know. It has to be obviously issued by a DEA registrant, but it has to be for a legitimate medical reason in the usual course of professional practice. DEA does not set what in the usual course of professional practice is. That's your boards, your medical boards, or your pharmacy boards. We do not practice medicine, nor should we. So we need to stay in our lane. So remember that. But is the arm broken? The bad doctors, that's a bad word, I guess, the bad doctors don't care. There's no legitimate medical reason. They're not following up with tests, x-rays, those kinds of things to determine that there's a legitimate medical reason. And then again, would your peers prescribe in the same manner? So that's federally, that's it. That's what a valid prescription is. We don't define medicine, nor do we set limits to the quantity of a prescription. Just a prescription written for a high quantity might be a red flag, doesn't necessarily mean it's illegal. But we do not set the quantity. That's a medical decision that kind of falls under the medical board. But some state providers do, and I think some states do limit what the first initial prescription can be. But here's that the pharmacist, I thought she did a phenomenal job. The pharmacist has a legal corresponding responsibility to make sure that it's a legitimate prescription. So there's this where physicians and pharmacies should be on the team. Team Gallagher is a patient. They should be rooting for me. Sometimes they fight a little bit, but they have a legal responsibility. Drugs of a concern. Right now, I'm going to skip over this because I think you've gotten this, but obviously hydrocodone. State of Michigan, you love your hydrocodone. I'm going to show you. Look at this. So this is the aggregate data of hydrocodone that moves into a state to pharmacies. You are number 3 after California and Texas. And I come into your state and I go, why? And I'll tell you, Michigan is a source city for hydrocodone and oxycodone that's leaving here, going to Ohio by gangs, being trafficked through gangs to Ohio and Texas. Ohio and Kentucky. I thought all the drugs were coming up from Florida. It is coming Michigan down, and I want that stopped. I do not want to be a source state, and we are right now, look at that. So we're going to look at that through education and enforcement. We've got to educate pharmacists, we've got to educate doctors, everybody, but that just, population-wise, something's wrong there, right? Okay, so I'm going to jump ahead. For oxycodone, you're somewhere, what is that, 16th? So maybe that's doable, I don't know. But number 3, we're going to change that. Methadone, number 2. Now, is that methadone being prescribed? I don't think that's in drug treatment. I don't know. I've got to look at that. I'm only a Michigander. Gander. I'm saying it right? Gander. I love your accent. I'm only 4 months old. See, I'm half the MIT. I got to be 5 months old. Okay. Yeah, methadone, you're number 3. So we have to figure it out. So real quick, because I definitely didn't have enough time. There's lots of different methods of diversion that we look at. Practitioners or pharmacists, what we see are illegal distribution, basically cash, greed. You give me cash, I give you drugs. Self-abuse, sad, that's there, and then trading drugs for sex. I've been called a perversion investigator since I was 22. I'm 54. So we, that's kind of our area there too. Where is diverting? Obviously, employee pilferage is huge. Hospitals, practitioners' offices, nursing homes, retail pharmacies. Addiction is addiction, and people do desperate things. So we'll look at employee pilferage. We generally don't investigate so much. I want to look at that pharmacy and say, how is it so easily being stolen from your store within? Where are your safeguards we want to look at? Pharmacy, we have armed robberies, burglary, in-transit loss, and then for the prescriptions, we have well-organized prescription rings, doctor shopping, and whatnot. I want to touch base on the violence. Look at this young man, handsome, young, 26 years old. He straps fake explosives around his belly and says, I've got explosives, goes into a pharmacy and wants Percocet and Xanax. Armed robbery usually is a crime of desperation, right? If you're at a point in your life where you're going to go in and threaten harm, again, you're at the lowest of low. And a lot of times pharmacists are being killed. It's so tragic. But I look at this young man's face, that could be my son. It makes me so sad. Nationwide, pharmacies are the ones that receive the most armed robberies, employee pilferage, and night break-ins. Let me just get to Michigan here. Michigan, most of your thefts are employee pilferage. So if you're in a facility, hospital, doctor's office, remember that. You know, generally it's usually Mary who's worked for you for 20 years, and Mary would never steal from me. Well, Mary's got a drug problem, and Mary's stealing from you. If you're not watching your shop, it's always Mary or Cathy. You know, Cathy. Night break-ins, armed robberies, you had 15 and 20. In 2016, you had 12, so you went down. And I did. Look what county is the top of armed robberies? Wayne County, 4. You know, and if you have any pharmacists have been a part of an armed robbery, they'll tell you one's enough. It's scary. And then you can see the other counties there. I'll move quickly. You know the deal from oxycodone, you know, hydrocodone, pharmaceuticals. We've got a heroin problem. This is what I want to talk about. We talked about this today. DEA, law enforcement, we can't arrest our way out of the problem. Collaboration is the key. How do we do it? DEA is going to hold industry accountable. We're going to ensure compliance through education and enforcement. I've been taking notes because I'm going to start a physician continuing education program, hopefully in the fall or in January, and I already know who's going to be on my agenda. Thank you very much. You didn't realize you volunteered yourself today, but you did such a good job. I know who I need there. Effective state control laws. You really, as a state, need to look at what your laws are and help the treatment of provide good medical care. But the thing is, we've got to teach our patients, teach your family members to secure your medications. Secure, secure, secure. We have to dispose of it. You know, once you have it, you think, my knee's going to hurt again. You know, we don't want to get rid of it, and I paid for it. It's changing a thought process. Access to treatment is clear, and I think demand reduction, we have to go to grade school. We almost have to bypass middle school. I mean, you don't stop there, but we have to start. And so today we heard that. How you do that. We talked about our disposal. We started this as just a way to just get drugs, educate, and my time is up. So I'm just going to, you know about this. Okay, so here's some stats. But Dr. Dudley, you had asked last night, and I didn't have the stats for Wayne County. Wayne County, you collected, wait, I got to write this down. Are you ready? Okay. So Wayne County, 1,578 pounds. Macomb County, Macomb, am I saying it right? Macomb, I practiced that. Did you know Washington has an R in it where I come from? I just want to show you know that. Macomb had 2,579 pounds, and Oakland had 3,507 pounds. So Wayne, my son's middle name is Wayne, so Wayne's a special name to me. But I'll tell you, Michigan, we went up. Detroit PD, you went from 8 pounds to 35 pounds. We need some work in Detroit City. I mean, I need to lose 35 pounds, but I mean, that's not a lot of weight, you know, that we're collecting for the whole city of Detroit. I can say Detroit PD, we got more collection locations, but what we hear is, well, no one will give up their medications. They'd rather sell it. And that's an insult to me, right? We need to educate people how to get rid of it. And I heard that discussion today. And then we have collection receptacles in pharmacies, long-term care facilities can have it, opioid treatment programs can have it, police departments. These are some, I'm going to just jump here. So the last thing I'm going to leave you with is 360 strategy, which is what you all are doing. We started this new program across the country. We pick cities where we deploy healthcare providers, community-based organizations. We come together and we do exactly what we're doing, but with funds, a lot of funds. I wish I had more time on 360, but if you go on our website, you can hear about it. I'll probably, now that I'm here, we'll be talking about it. We have Louisville, Kentucky. Did I say it right? I'm having problems. Louisville. Sorry. And Dayton. I can say Dayton, Ohio. We don't have any in Michigan. But we have federal, if you go on our website, we have lots of information. But I thank you so much for doing what you're doing. I have left here so hopeful. I can't wait to do the work that I need to do here in your state. And I've already met people, and we're going to have good partnerships, and I'm going to be at the June 14th meeting. So thank you for adopting me. Good night.